Hello, everyone, and welcome back to this course on child and adolescent health in humanitarian settings. Today, we will discuss the second half of Module 3 on response. My name is Kim Beentjes, and I'm a technical officer working at the WHO Eastern Mediterranean Regional Office in Cairo. So today's module will be based on the Child and Adolescent Health in Humanitarian Settings Operational Guide, as the previous modules were as well. Then these are the 4 interconnected programming action areas of the operational guide. And today, as last week, we will focus on respond, which is how to plan and enact a coordinated set of activities addressing the identified child and adolescent health priorities. This is the index of the guide, and today we will focus on part of this. So we will discuss child development and education. We will discuss disability, psychological distress and mental health, sexual and reproductive health, WASH, how to strengthen the healthcare workforce, obtaining essential medicines and medical supplies, and obtaining fundings. So last week we discussed how to decide on an essential service package, and we discussed the first themes that were included in that. And today we will continue with this. So this will include, so last week we did up until nutrition, and now we will start with child development and end with WASH. So the first topic of today is child development and education. Here you can see the components of nurturing care, and nurturing care is essential for child development. We also have a video this week from an expert that talks about nurturing care and early childhood development more. Early childhood development should be integrated into all humanitarian actions, and this is because children in conflict often face compounded risks to their development due to experiences with displacement, migration, and resettlement, which may include integration into new settings like refugee camps or host communities. And this could also cause toxic stress to the children, and this affects their development in general. You can scan the QR code in this slide to make a puzzle based on these components of nurturing care. Then I will tell you a bit more about nurturing care and what it is. So nurturing care refers to the conditions needed by children to reach their full potential. Keeping children safe, healthy, well-nourished, paying attention and responding to their needs and interests, and encouraging them to explore their environment and interact with caregivers and others. This has 5 components. It starts with good health of both the children and the caregivers. It includes adequate nutrition, both for mothers and children. It includes safety and security for children and their families, opportunities for learning, and also responsive caregiving. Then a bit more on education and early childhood development. Education is vital during the emergencies to sustain communities, and it's crucial for development and well-being of kids. It provides physical, psychological, and cognitive protection, and it enables early identification of at-risk children and also those with additional needs. It shields children from dangers such as exploitation, early marriage, and involvement in crime. And it also equips children with problem solving and critical thinking skills. Additionally, educational venues serve as hubs for delivering essential support, and this can include daily meals, WASH education, and health services. And schools also promote inclusion and equality through equitable access for high-risk groups. Then these are some nurturing care recommendations for people living in humanitarian settings. These actions can be tailored to different phases of emergencies, and the interventions can be adjusted to contextual factors such as the duration and the type of humanitarian or security issues. So the first one is ensuring responsive care for infants and children in the first 3 years of their life. Encouraging early learning activities with parents and caregivers during the first 3 years. Then it also includes integrating support for responsive care and early learning into nutrition interventions for infants, and to integrate psychosocial interventions for maternal mental health into early childhood health and development services. Then as for the previous modules, in this one, we also discussed the key actions, this one on child development and education. It's recommended to integrate nurturing care in humanitarian actions. The working group collaborates with education and other sectors to integrate nurturing care for children in humanitarian action. And here you can also refer to Annex 5 and 6 of the operational guide for more information on this. And it's also very important here to share health promotion messages and information on early childhood development and nurturing care. Then the key indicator that is linked to this is that the working group and the lead education cluster agency have regular meetings to strengthen coordination of activities. Then the next part is on disability. This is separate from the chronic conditions that we already discussed, and here we will focus on the disability inclusive approach in humanitarian settings. So disability is an umbrella term that covers impairments, activity limitations, and participation restrictions. And during crisis, people with disabilities are more likely to be left behind, abandoned, or neglected. Disasters and armed conflict increase the number of children and adolescents with disabilities, and to increase resilience, this should be considered when preparing for humanitarian emergencies. People with disabilities are often overlooked, which then can result in inaccessible and inappropriate services. And humanitarian agents must therefore ensure inclusive and appropriate actions, especially for children and adolescents with disabilities. Disability inclusion is crucial across all stages of humanitarian planning and also during humanitarian delivery and evaluation. There's heightened risks for children and adolescents when their coping mechanisms and support systems are compromised. And challenges here include the loss of assistive devices, medications and social supports, and also increasing dependency of caregivers. Then there might also be problems with accessibilities. There can be social stigma and negative attitudes that can prevent access to the mainstream humanitarian services and to food distribution points. Children and adolescents are particularly vulnerable to abuse and neglect, especially when they have disabilities. And in the planning of humanitarian actions, it should be considered that caregivers can also have disabilities, which should be included so they can respond to the needs of their children. The key actions that are linked to this are promoting disability inclusion. The working group and their partners should promote disability inclusive approaches in all activities. And we have an annex of this in the operational guide, which is Annex 7, which provides more information on this. Then we should also include children and adolescents and their families into the planning of disabilities during humanitarian action. And in this, we should promote independence and self-management. We should also ensure that assistive devices are available for children and adolescents that have mobility or communication issues. And we should challenge discriminatory attitudes and promote equity. The key indicator linked to disability here is that all healthcare providers and partner agencies have adopted policies on disability inclusive action and are translating these into concrete actions in their humanitarian response. Then the next topic is psychosocial distress and mental health in humanitarian settings. Humanitarian emergencies expose children and adolescents to psychosocial traumas. This can include displacement, food insecurity, and armed violence. And emergencies also weaken familial and community supports, which escalates risks of psychosocial issues, and it can exacerbate problems that were already existing before. Children of all ages can express distress. This can be through regression in their development. They can experience anxiety, sleeping problems, and their behavior can change both inside schools and outside of schools. Then another significant concern for children and adolescents in humanitarian settings is substance abuse, and this can especially be dangerous and occurring in individuals that are in the armed forces. Many young people face losses and require support for grief and bereavement in humanitarian settings. And humanitarian emergencies can also unmask, trigger, or exacerbate serious mental health problems. And this can include depression, anxiety, and PTSD. So the key actions that are linked to this are promoting good mental health and well-being. The working group and partners should work with child protection, education, and other sectors. It also includes ensuring availability of basic clinical mental health care. This should be done at every facility for priority conditions. Priority conditions include depression, anxiety, and post-traumatic stress disorder. We should protect the rights of people with severe mental health problems. This should be done at communities, hospitals, and institutions, and this can include schools and workplaces. Then we should strengthen pre-existing community networks for psychosocial support to children and adolescents. Focusing on community networks can provide support to the most vulnerable groups, which can help them cope with stress and building resilience. Then the indicators that are linked to this are that the working group and partners have identified mental health priorities for children, adolescents, and their carers and families in collaboration with the health cluster. And then the second key indicator is that basic mental health services are available at every facility. Then the next topic is sexual and reproductive health. Sexual and reproductive health can affect children of all ages. And adolescents require culturally sensitive information for safeguarding their sexual and reproductive health. Children and adolescents face more risks of sexual exploitation, violence, and forced marriage. So this requires an adolescent-friendly support for them. Then pregnant adolescents are also of greater risk for complications than pregnant adults. And this can happen during pregnancy, but also during childbirth. Then these are some numbers that highlight why it's very important to include this into humanitarian actions for children and adolescents. This is on sexually transmitted infections and unsafe abortions. So 50% of new HIV infections occur in people aged 15 to 24 years old. And 1/3 of the new cases of curable sexually transmitted infections affect people under 25 years. And then on abortions, annually 5 million adolescents between the ages of 15 and 18 years have unsafe abortions, causing 70,000 abortion-related deaths. Then there's heightened risks for children and adolescents during crisis for the following things. This includes early pregnancy. Children and adolescents often have unmet needs for contraception and unwanted pregnancies. There's higher risks for HIV/AIDS and other STIs. There's a higher risk for unsafe abortions. There's a higher risk for sexual and gender-based violence in all forms. And there's difficulties with the management of their menstrual hygiene. The then key actions that are linked to this are promoting adolescent health, collaborate with clusters to establish education and referral services, source and produce contraceptive supplies and ensure availability to everyone, and training community workers for community-based family planning services. Then the next one is addressing gender-based violence, coordinate health sector efforts against sexual violence and provide comprehensive care for survivors. Also raise community awareness about gender-based violence. Then the next one is enhancing maternal and newborn care for adolescents. Make sure there's a 24/7 referral system for obstetric emergencies and provide adolescent-friendly maternal and newborn care, while coordinating identification of pregnant adolescents in community among the clusters. Then on preventing STIs in adolescents, provide discreet access to free condoms at adolescent-oriented points, and establish comprehensive prevention and treatment services for STIs. And this also includes offering care, support, and treatment for people that live with HIV. Then the indicators that are linked to this is that the working group and partners have developed and communicated a plan to address sexual and reproductive health issues across the lifespan. Then gender-based violence programs have been established and referral pathways for children and adolescents are available and appropriate. And all service, including obstetric and maternal services, are adolescent-friendly. Then the last topic on service delivery is WASH. Fecal oral diseases can contribute to over 40% of deaths in the acute phase of an emergency. And overcrowded WASH facilities can be a considerable threat to children's safety. WASH implementation may enable children and adolescents to attend school, and this is especially important for girls. Then when designing refugees, shelter, and WASH facilities, it's essential to ensure that this is also safely accessible for women and girls especially. Consider and meet the WASH standards of individuals with disabilities as well, and also individuals with chronic health conditions. Then the main objective of WASH programs in humanitarian settings is to reduce the risk of fecal oral diseases because these are very high, and the exposure to vectors that can carry disease. This is mainly achieved through 4 things. The first one being promotion of good hygiene practices. Second one is provision of safe drinking water. The third one is the reduction of environmental health risk. And the last one is provision of conditions that allow people to live with health, dignity, comfort, and security. Then the key actions that are linked to this are collaborate on holistic WASH programs. The working group should collaborate on comprehensive WASH with cluster leads, and implement the WHO's wash fertility improvement tool for health facilities. Then on engaging communities and assessing risks, engage communities and stakeholders for wash risk and coping strategies, and identify public health threats, assessing behaviors and training for monitoring. Then promote children's wash needs, emphasizing hand washing and safe water. Consult for hygiene items and develop menstrual hygiene solution while ensuring appropriate facilities. Then the last one is define an infrastructure and manage the environment. Define structures for water management that are sustainable short and long term. Determine safe excreta management, considering gender and culture of the area that you're working in, and collaborate for a clean environment with waste and vector control. Then the indicators that are linked to this are that the working group and partners have contributed to the WASH sector program, and that they regularly meet for support of program implementation. The second one is that you should achieve 100% of affected populations to have suitable hygiene items such as water and soap for hand washing, and achieve a 100% satisfaction with consultations on menstrual hygiene management systems, including toilets and disposal systems. Then we're moving on to the next part of Module 3, which is strengthening the healthcare workforce. There's a lot of challenges that are faced by local healthcare workers in emergencies. Local healthcare workers have a triple burden during emergencies. They're often recovering from personal injury and loss while assisting their family and friends, and then also providing healthcare to the broader population. During emergencies, there's often loss of skilled healthcare workers, which is a challenge. And healthcare needs during emergencies are often greater and also different, which requires varied skill sets and expertise from healthcare workers. Key actions that are linked to this are evaluating and planning workforce responsing. So collaborate with health cluster leads to assess the current health workforce capacity and the needs. Also to optimize staffing levels, reviewing existing staffing levels using national standards adapted to the settings that you're working in. Then have coordinated recruitment and training, collaborating with governments and health facilities for staff recruitment, training, and development, and recruit a diverse staff matching skill needs, gender, ethnic ratios, and considered paid and volunteering roles. Then integrate the local health workers and provide support, include local health workers in the emergency response, and provide flexible working conditions, training for new roles, and support during crisis situations. Then the indicators that are linked to this are that the working group and partners have supported the health cluster to evaluate the current health workforce capacity and needs and establish a plan for response. Then also ensure the availability for health workers. So here it's recommended that there is 1 to 2 community health workers per 1,000 population and around 23 qualified health workers per 10,000 population. Then we move on to the fourth part of Module 3. This is obtaining essential medicines and medical supplies. The slide is on efficient supply chain management. So assess current supply chains before acquiring more to avoid overstocking or understocking. Adjust orders based on potential disruption and changing health needs in the emergency. Then collaborate with the World Food Programme-led logistics cluster for effective coordination and information management. and consider distributing UN emergency kits for acute crises with supply disruptions. The key actions that are linked to this are collaboration for prioritizing supplies. The working group and partners should collaborate with health clusters and sector leads to assess and prioritize essential supplies for children and adolescents. You should evaluate existing supply chain and order lists before rushing to obtain more to make sure you don't over or undersupply regions. Then establish and use standardized essential medicines and medical device lists based on essential services packages and service delivery plans, and advocate for critical inclusions. Ensure the availability of safe essential medical devices through an effective management system, and effect donations of medicine and medical equipment only if they adhere to international recognized guidelines. So make sure you need things that you accept as donations. Key indicators that are linked to this are the total number of days that key medicines were not available in the past 30 days. So this can, for instance, include paracetamol or oxytocin. Then the total number of days basic equipment was not available or not functional in the past 30 days. And this can include blood sugar machines, pulse oximeters, thermometers, scales, soap, etc. Then the last part of Module 3 is obtaining financing. These are some recommendations on essential services funding. Health agencies should proactively identify funding needs for training, material development, procurement, salaries, and other service delivery costs. And here it's very important to acknowledge that humanitarian funding processes can be slow. So plan for delays from proposal development to fund approval and provision. Also be proactive in seeking potential donors early on in the process, and utilize experienced grant writers to enhance the effectiveness of the proposals. Then I'm going to go into a bit more detail on the UN Central Emergency Response Fund, or CERF, which was established in 2006 to receive and disburse funds for the UN's global emergency response. So donors can contribute to CERF before urgent needs arise, and then CERF pools these donations into a single fund. Then at the same time, aid workers identify the most urgent type of life-saving assistance that affect people in need, such as shelter, food, clean water, and medicine. And then UN agencies and their partners work together to prioritize life-saving relief activities, and they request CERF funding through the top UN official in the country. Then these two streams come together into allocating funds based on expert advice from the aid workers on the ground. The emergency relief coordinator distributes the funding that CERF received, which then should lead to relief organizations using the money for life-saving aid operations. And they also track spending and impact and report back on CERF on people reaching the CERF funding. So the key actions here are that the working group collaborates with partners and the health cluster lead to identify funding needs and potential donors proactively. Then the health service providers aim to identify and mobilize financial resources to offer free healthcare during emergencies. Health services providers aim to abolish or suspend user fees for the duration of the emergency, making sure there is healthcare for everyone. Then organizations provide support to the government health facilities to cover financial gaps resulting from the abolition and or suspension of the user fees. And then the key indicator that is linked to that is that provision of primary healthcare to affected population is free of charge at all government and non-governmental organization facilities for the duration of the humanitarian response. Then there's some resources and tools that you may want to use. So we have general resources and tools for this module, but we also have specific information on some topics. So please, for this, refer to the operational guide, pages 74 and 75 and 77 to 79. And here there's also specific resources on child development and education, disability, psychosocial distress and mental health, sexual and reproductive health, and WASH, which is the topics that we discussed today. But thank you very much for your attention. And if you have any more questions, please reach out to me or Khalid. Thank you.